Hi, everyone. Good afternoon, and welcome to the MDS panel. It's a great pleasure to be here this afternoon, and I'd like to congratulate the Aplastic Anemia MDS Foundation for this wonderful event and for the 40th anniversary. So I'm moderating this panel, and our panelists are Dr. Papa Manuel from Memorial, who's going to focus on molecularly inspired prognostication in MDS. She's going to be joining us virtually. Dr. Valeria Santini will focus on treatment of lower risk disease, and she's also joining us virtually from Italy. And then we have Dr. Arts, who is from the City of Hope. Thank you, Andy, for joining us all the way from California. And he's going to focus on transplanting MDS, in higher risk MDS. And I will be speaking on just where we are with the treatment of higher risk MDS today. So it's wonderful to be joined by all these colleagues, and I am really looking forward to a stimulating discussion and session. Thank you all so much. So I think we are going to kick it off with Dr. Papa Manuel. Hi, Ellie. I hope I got your name right. I'm really sorry. I should have called you in advance.
All good. All good. Thank you so much for the invitation. I'm sorry I couldn't be there in person, but I'm very grateful for the opportunity to share some of the work that we have been doing in collaboration with the International Working Group for MDS in the development and validation of the IPSS molecular. So today I'm going to give you, this is published work, but I'm going to give you a high-level overview of how we went about designing the model, validating the model, and also some information on what has happened since the publication of the model with regards to its adoption globally. So, of course, in this audience, I do not need to provide much background in that, kind of in the absence of a large repertoire of targeted therapies, which many other solid tumors benefit from. Really, in the context of MDS, risk stratification does remain the backbone of treatment decisions. And there have been numerous risk stratification schemas developed over the past 20 years or so. But the one that has been very broadly adopted since its publication is the revised International Prognostic Scoring System, which effectively took into account clinical and cytogenetic parameters to stratify patients into one of 5 groups. And that would identify patients that were low risk with regards to which had favorable outcomes with regards to overall survival and minimal transformation or disease progression rates to AML transformation, as opposed to patients that had intermediate or high risk, being those patients that had very low overall survival estimates and a high degree of transformation or progression to acute myeloid leukemia. So since the publication of the IPSS-R through efforts of our international community, of course, we described and characterized the number of genes that are recurrently mutated in MDS. This is the seminal study by Rafael Behar. And we understood that many of those gene mutations do have prognostic are likely to be relevant with regards to prognostic and risk stratification. However, these genes had not been embedded into a unified risk stratification model. And over the course of years, a number of efforts demonstrated proof of principle concepts or models whereby the incorporation of information from gene mutations to clinical parameters and cytogenetics could deliver improved risk stratification for patients with MDS. And this is important because we know that almost half of MDS patients do not harbor cytogenetic abnormalities. And therefore, if we remained in using the IPSS-R for those 50% of patients or so, there would be no molecular information incorporated into the risk estimation for those patients. So we rather than take a single center approach, we decided to go the hard way and really engage the international MDS community. And here you can see a map of many of the contributing centers on the left, as well as the colleagues that were part of this effort, which contributed samples that were all sent to Memorial Sloan Kettering, as well as clinical data. And on the top right, you see members of the oversight committee, which over the course of the years help us with both study design, execution, data analysis, and interpretation. So although we aspired to collect about 5,000 samples, and we did bring about 5,000 samples into MSKCC, our high quality cohort was just under 3,000 patients. You can see that this was a representative MDS cohort. These are all diagnostic samples and was representative with regards to age and clinical parameters. All the samples were brought into MSKCC, where we deployed a high-depth targeted gene sequencing panel that captured 121 genes that were recurrently mutated in MDS. And we annotated mutations that were known bona fide oncogenic mutations across those genes down to a variant allele fraction of 2%. And we incorporated information from clinical cytogenetic findings at the respective centers. In addition to the training cohort, we leveraged data from a validation and external validation cohort, which had been independently sequenced and annotated as part of the Japanese MDS consortium. And this is important because the fact that the sequencing, the panel, and the annotation was done independently renders this validation cohort as suitable to validate the overall approach rather than design and validate a model that's very intrinsic to the way we perform the sequencing or annotate the data. So the endpoints of this exercise was to develop a molecularly guided risk stratification model that would give both a patient-specific score, but also would deliver, similarly to the IPSS-R, distinct risk strata, where patients could be grouped into low, intermediate, or high risk subgroups that could support clinical decision-making in the future. Now, we used leukemia-free survival as the endpoint to make it very as similar as we could do with the IPSS-R. The model was adjusted for X, sex, and MDS type. To keep it as an evolution of the IPSS-R, we retained the cytogenetic categories as they have been incorporated, adopted, and used over the past decade by the IPSS-R. And then we identified a set of 17 genetic variables from 16 main effects genes. And these are genes that were identified to have either adverse or favorable associations when it comes to outcome predictions. In addition to that, we considered 15 genes that in univariate analysis had associations with outcomes that we called residual genes in order to capture any risk that's associated with the broader genetic landscape, mutation landscape that's present in those patients. Then we developed a formula which very much just adds takes into account the coefficients associated with each one of those risk variables, sums them up, and develops a patient-specific risk score. This risk score was something that is unique to this model, is that this risk score was scaled to an average patient, and it was interpretable in that if one were to look at the scale of the risk score, the relative difference in the number of the score indicates kind of the relative difference in risk between two patients, whereby a change of 1 point in the score would indicate a doubling of risk between two patients. So there is an element of intrinsic interpretability in the way the score was scaled and formulated. But of course, for clinical adoption, it's very hard to define guidelines that are specific to a continuous score. And for this reason, we also separated patients into 6 distinct risk strata. This is very similar to the IPSS-R in terms of the very low, low, high, and very high risk categories, with the only difference here is that we took the intermediate risk group and we separated it into a moderate low and a moderate high risk group. On the left, you see for both endpoints, leukemia-free survival and overall survival, that the groups separate, provide very good separation amongst the patients. And when we compare across the 3 endpoints, leukemia-free survival, overall survival, and leukemic transformation, we achieve significant increase in the prognostic in model discrimination by means of the C index for the IPSS-M, both the continuous score as well as the categorical strata. So what does this lead to, and what is the overall added benefit of using the IPSS-M as compared to the IPSS-R? Here we demonstrate a plot whereby on the left, we divide patients across the IPSS-R risk groups, and then we show how the patients that, for example, that belonged into the IPSS-R intermediate risk group, how they now distribute on the base of the IPSS-M risk score. So overall, what you see is that there is very broad separation in risk groups in patients that were previously considered intermediate, which includes almost 40% of patients, or just over 60% of patients, being ascribed to either a moderate high, high, or very high risk score, with the remaining patients falling within a moderate low or very low group. Overall, if we were to take our patient population as a whole, almost 1 in 2 patients, so 46% of MDS patients, would re-stratify in risk category when comparing the IPSS-R with the IPSS-M, and 2/3 of the restratified patient, or 3/4 of the restratified patients, would be upstaged in risk, and that of course could have important therapeutic implications. 7% would be restratified by more than 2 risk strata. What was also quite interesting is that in our cohort, and I don't have time to go into too much detail on this, we had about 250 patients that were diagnosed as secondary or therapy-related MDS. And what we see, although we know that typically patients that fall into this category are associated with high risk, and in fact, we do note here, when compared to the de novo patients, almost 50% of those patients were high or very high IPSS-M. There was still a significant proportion of patients that fell within low risk IPSS strata. And here what we show is that when you look individually within the IPSS-R strata, they seem to track outcomes even in what we have conventionally considered to be a high risk group. So this shows that a molecular risk stratification can further provide prognostic context within clinical subsets that we have previously considered to be exclusively associated with high risk. So in wrapping up this presentation, this effort not only provided us with a model, but it also provides us with, by understanding which genes are relevant when it comes to disease prognostication, it identifies a number of genes that are important for us to genotype during the diagnostic workup of MDS patients, as well as how these genes may be encoded. An example includes that we need to differentiate TP53 multi-hit patients to TP53 monoallelic cases because only the multi-hit had prognostic information, that we need to map and report mutations in MLL-PTD, but also that we need to discriminate mutations in SF3B1 on the basis of the genetic context in which they occur. And here we show that SF3B1 may fall into 3 different genetic clusters, one associated with deletion 5q, one associated with mutations in RUNX1, BCOR, or STAG2 that's associated with more adverse risk, both of these groups. And it's really only the SF3B1 alpha cluster that's associated with favorable risk. And this information not only has translated into the IPSS-M, but also has directly provided guidance into both the WHO and ICC classifications, as you can see here with regards to the parameters by which an SF3B1 group or a P53 mutation should be considered. Beyond diagnostic assay design, we released the IPSS-M web portal, which is hosted by the MDS Foundation. The portal is a user-friendly web calculator. We've also released an Android app and an Apple iPhone app, and the website is now translated in multiple languages. And since the publication of the IPSS-M, there have been more than 148,000 computations for patient risk scores in over 80 countries. And there have been more than 30,000 unique users. And on average, the calculator is accessed about 160 times a day from anywhere around the world. Last, we've released all our data. We have made all of the data and code publicly available. And we released an R tool that allows you to calculate in batch, provided you have the right input data, the IPSS-M score for your cohort. And that really enabled within 6 weeks of publication to the deadline of the ASH abstracts last year to see real-world validation of the IPSS-M across different contexts in more than 10,000 patient samples that were presented at ASH 2022. And we look forward to see what the community has done with this in the next meeting. So to summarize, using 3,700 patients, we trained and validated the IPSS-M, which redefines risk for 1 in 2 MDS patients. And we really developed a model that is very transparent in that there is a clear mathematical formula with specific coefficients that anyone can plug in and calculate for a given patient that results into a personalized and interpretable risk score. And we provided a tool that enables widespread clinical adoption globally. I didn't go into this, but the tool, given the fact that many of the diagnostic assays do not necessarily report many of the features as we produce them in the IPSS-M, the web calculator does handle missing values or can account for missing data for features such as the biallelic P53. And we've also released a tool that allows the community to really validate, but also extend studies beyond the IPSS-M. So for that, I would like to thank all the participants in the community and the broader MDS community that frequently provided us with feedback as we developed the model. Of course, Elsa Bernard, that spearheaded all the development, analysis, and validation of the model, Juanes, who built the calculator, and everyone in the oversight committee who stood by us and helped us to develop and deploy the IPSS-M. And you for your attention, and I'll be happy to discuss this, I think, at the end of the panel with the rest of you, unless you want to do questions now.
Thank you so much for that excellent presentation. So, Dr. Santini. Hi, Valeria.
Hi.
I think you're next. Yeah, Dr. Santini will talk to us about advances in the treatment of lower-risk MDS.
Thank you. I'm really grateful for this invitation that allows me to participate to the celebration of the anniversary of the Aplastic Anemia and MDS International Foundation. I'm trying to give you some ideas and highlights of the advance in the treatment of low-risk MDS. This year has been somehow the year of low-risk MDS. So the new therapies are there. So I have this picture that I designed myself. As you may see, it's quite ugly, but it's quite clear as well. So I'm affectionate to that because you see in red, I just highlighted the treatments that have been approved for MDS. As you see in red, these are all the treatment for lower risk MDS. And then you have, hypomethylating agents here that are half red and half black, because in Europe, we cannot use them for lower risk MDS. They are approved only for higher risk, but indeed, they are effective also in low-risk MDS. In purple, I have the studies that unfortunately didn't get successful results, and only one, roxadustat, is the one that was targeting low-risk MDS. In black, eltrombopag and imetelstat, who have been successful, and papers and articles have been showing activity in low-risk MDS, but have not yet been approved. So I will discuss some of these drugs. And indeed, after the outstanding presentation of Ellie and what she said about the upgrade of all the MDS from IPSS-R to IPSS-M, I just want to stress the fact that the majority of lower risk MDS patients have been reevaluated by IPSS-M, and a proportion of them, as you may see below here, can be upgraded even substantially to higher risk categories. So maybe we will have to distinguish among the previous lower risk MDS patients in the future and redesign studies. What has been interesting in the past has been that we had several options for anemia, which, by the way, it's anyhow the most frequent cytopenia in lower risk MDS, and not so many options for other cytopenia. I will not go into details of discussing the immunosuppressive treatment. There are many studies, heterogeneous. We just heard about aplastic anemia. And I think that we will have to develop and rethink about this approach deeply. We have new categories of hypoplastic MDS in WHO. So we may have new tools to select patients also for this treatment. We have not much for neutropenia, and I will discuss very briefly the approach to thrombocytopenia. So I will keep on discussing the novelties about the treatment of symptomatic anemia. And you see, after the new drugs that have been approved or are just going to be interesting in this sense, we have a group of patients that in this moment is not yet eligible for new treatments. And these are the patients who have been to be kept on supportive therapy, transfusion, iron chelation. So we will have to target this subgroup of patients of lower risk MDS as well. And of course, some of them will respond to hypomethylating agents, oral, low dose, but we have to consolidate the data for the lower risk MDS patients. Now, a very interesting approach has been pursued by the French MDS group. There has been a small study, but very challenging, in which patients with IDH1 or IDH2 mutations and low risk and anemic were treated with monotherapy, ivosidenib or inazidenib. So this is a very small group of patients indeed, but the results that were shown, although again, in a small cohort, were very interesting, with more than 50% of overall response rate, especially for IDH1 mutated lower risk MDS patient, and more so partial response in IDH2 mutated. But the interesting thing about this study is the approach. So this was a more complex study than I show here, with 3 arms, with higher risk de novo and relapsed MDS. But the interesting issue here was to target also lower risk MDS with a target therapy. So I was very interested, and I think the study is going on still. Then, of course, we had last year the novelty of the approval of luspatercept because of the activity in inducing transfusion independence in transfusion-dependent lower risk MDS with ring sideroblast. Everybody now knows exactly, I don't have to tell you what is luspatercept, is a ligand trap, and it's able to induce almost 50% of transfusion independence longer than 8 weeks in lower risk MDS patient carrying with showing ring sideroblast. This is why it was approved. And in August 2023, there was also the approval of the first-line treatment I will discuss later. But what was interesting, and the concept is interesting, is that luspatercept can induce transfusion independence, but the period in which the transfusion independence is achieved can be given by multiple episodes. So if we follow up patient for 24 weeks, we have a percentage of them having a transfusion independence longer than 8 weeks. If we prolong therapy and observation, this number is going to increase. And the duration of the response is also quite interesting, the median duration. What was also interesting, and I would say not completely unexpected, but not so relevant in the beginning and evident, was the fact that even neutrophil and platelet could increase upon treatment with luspatercept, meaning that this agent can sort of move and induce hematopoiesis beside erythropoiesis only. So I think this is an interesting concept. Of course, you have to compare to placebo, that could also let us observe some improvement, but it's the concept of targeting anemia, but also obtaining an improvement in the rest of the hematopoiesis. This is the first-line study with the same agent that I think it's an interesting proof of concept, and actually, in my opinion, opens new avenues to understand which are and how dysplastic hematopoiesis can be stimulated and respond both to EPO and luspatercept. So the common study included patients with lower risk MDS, very low, lower intermediate, with and without ring sideroblast. And of course, this patient had to be transfusion dependent and with an endogenous EPO below 500 units liter, and ESA naive because luspatercept was compared to EPO alpha treatment. The interesting fact of this study was also that the primary endpoint was not only transfusion independence, and here you see longer than 8 weeks, a little bit more clinically relevant, 12 weeks, and concurrent increase in hemoglobin of more than 1.5 gram deciliter. So the two parameters together were sort of giving us more intense idea of how was the clinical and the advantage for the patients. Okay, the drug was more active than EPO. You see the comparison is quite clearly indicating that almost 60% of patients achieved transfusion independence with luspatercept versus erythropoietin, 1/3 of them. This significant difference was observed also if you consider different level of EPO. Of course, with higher EPO, you have a lower response with the erythropoietic stimulating agent, of course. The transfusion burden was important. We knew, and we learned many years ago, that EPO is not effective if the patient is receiving many transfusion and the burden of transfusion is pretty high. So, but quite clearly, luspatercept does not depend on transfusion burden. The ring sideroblast status, on the other hand, impacts on response because the patient without ring sideroblast were responsive a little bit better to EPO than to luspatercept, although many of them, still 40%, could respond. And again, this is one of the points I think we will have to address. Who are the ones who do not respond to EPO and are prone to respond first line to luspatercept? Maybe we can sort of categorize and understand who are they and what are the characteristics. SF3B1 mutation, it's of course very, very important for response to luspatercept. I didn't mention the fact that in the registration trial for refractory patients who received already in the first line EPO and then in second line luspatercept, the ones who were more responsive were the ones carrying SF3B1 mutation that does not always overlap with the status of ring sideroblast. So this is something that is giving us a lot of work to do in the future, but also the fact that we have a complete different drug. So it's no longer a ligand trap, it's no longer activating, inhibiting TGF-beta or activin pathway, but it's a telomerase inhibitor. So in the beginning, when I started working on the phase 2, I had little bit of questions on the mode of action, mechanism of action, and the patients responded. And in this phase 3, I found that there were very interesting results. So the patient population was once again lower risk patient, but this time they were included because the study was started several years ago just by stratifying with IPSS, the old IPSS. Patients were transfusion dependent, refractory to ESAs, and they had a high transfusion burden, more than 4 units red blood cells in 8 weeks. And in all the studies, deletion 5q MDS are excluded, which is another point that we should address in future designs and in future study designs. They didn't have to have received lenalidomide or hypomethylating agents. Imetelstat was compared to placebo. Patients were stratified per transfusion burden and category of risk. The drug is an IV drug given every 4 weeks, and the endpoint is the achievement of transfusion independence. And the primary endpoint was met because 40% of patients achieved transfusion independence versus 15% in the placebo arm. Again, this is something that we should take into account because the 15% of transfusion independence in placebo is more or less is observed in all the lower risk MDS studies. And this is probably due to the fact that we consider a short period of transfusion independence, whereas also for the eligibility, we should consider a longer period of transfusion dependence to avoid this bias. Nevertheless, as you see, the significance was there. And what is more interesting in my idea is the fact that there were some patients who could achieve a very long transfusion independence, longer than 1 year. Of course, a smaller group of 18% of them, but you see that is a consistent, significant improvement and achievement of transfusion independence. Now, the difference with other approach is that apparently this drug has some disease-modifying effects because upon response, there is a decrease of the percentage of ring sideroblast in the bone marrow. There is a significant achievement of CR and cytogenetic CR and PR respect to patients who received were not achieving CR. And then when you treat with imetelstat, there is a significant decrease in the variant allele frequency of several mutations, the most frequent ones shown here. So it seems that really decreases the burden of the disease. We have to study more these aspects and clarify, but I think this is an interesting signal to follow. To finish, I said that we have a lot to do for thrombocytopenic low-risk patients. We don't have many options. Of course, we may treat with hypomethylating agents, but this study is a longer follow-up that Esther Oliva led, and the median follow-up is longer here and is eltrombopag versus placebo in lower risk MDS patient with thrombocytopenia. You see that the dose is quite variable from 50 milligrams daily to 300 milligrams. And what we observed was an increase of 42% in the number of platelets and a decrease in bleeding events, in transfusions, and the placebo arm, as it is clear, was not really decreasing significantly these bleeding events and this transfusion. So the relapse-free survival at 60 months is 63%. So these patients were keeping a very stable response for a long time. So again, you know very well, better than I do, the effect of eltrombopag and the mechanism of action. I think we will show, as others have shown, that is very active in MDS as well, and we need to go further in understanding how we may safely use this drug. And with this, I hope I gave you highlights and ideas to discuss, and I wish to thank the Aplastic Anemia and MDS Foundation for giving me this opportunity, my foundation in Italy, the MDS Italian Foundation, the people working in my lab, and also the European Myelodysplastic Syndrome Group. Thank you very much. I'm happy to answer any questions.
Thank you so much, Dr. Santini. That was excellent. I will go next, and my colleague, Dr. Arts, will conclude, and then we'll have a panel discussion. Thank you. Okay. Okay, thank you everyone for your attention so far. My talk is going to focus on higher risk MDS. It's a lofty title that I gave myself, which, I don't know how close, we will come to achieving that, but it is a dream that I hope that we will attain someday. So everyone is familiar with the fact that higher risk MDS is it's lethal by our conventional scoring systems, and that azacitidine was the first agent to really demonstrate that hypomethylating agents could potentially modify the disease relative to conventional care regimens, including chemotherapy. But over the past, several years, it's been clear that we have a ways to go. And this shows a number of trials, either where the hypomethylating agent was the experimental arm or the control arm, really underscoring the potential limitations. Many of you in the audience have contributed and labored over time to these results. We know that the duration of response is in the 10 to 13 or 15-month range. Sometimes a few studies outperform the average, and that overall survival is still pretty limited, largely in the 15 to 20-month range, and that deep responses are not common. And so we have issues of primary resistance, as well as secondary resistance, and relatively modest effects on the natural history of the disease. These are significant unmet needs, even in our current era. And so there's been a number of novel investigational therapies that have been looked at in high-risk MDS over time. This is not meant to be an exhaustive list. And I think I couldn't possibly rival the list that Dr. Steensma had in one of his slides, at the beginning of our session. But I wanted to just, briefly mention some of the advances in terms of having novel formulations now of azonucleosides, and then just briefly talk about novel post-translational modulators, immune checkpoint inhibitors, in particular magrolimab and sabatolimab, and then novel targeted agents, including venetoclax and the IDH inhibitors. I will not really be leaning into the early phase trials for many of these because I think the proof of the pudding will be in the results of the randomized studies. So we know that there's still a compelling rationale for targeting the epigenome in MDS, even in this age of precision medicine, and that in our realm, we're still really relying on the DNA methyltransferase inhibitors in that regard. As you know, they are S-phase specific, so need to be incorporated into cycling cells. Longer exposure would be desirable, but they have a relatively short half-life because they're rapidly degraded by cytidine deaminase. And so that had made the development of oral formulations relatively challenging, but we now have in the FDA-approved space for MDS an oral azonucleoside, which is oral decitabine that's combined with a potent cytidine deaminase inhibitor, cedazuridine. And the early phase trials was interesting in the way it was designed because the goal was really to demonstrate relative bioequivalence to the IV formulation, and that was readily achieved. But what was even more interesting was that the phase 3 trial was developed along the same line, which is looking at bioequivalence at 5 days, so the AUC over 5 days as the primary endpoint. This served as the basis of FDA approval for this agent, and it has now formed or is now forming the backbone of a number of other early phase trials in the higher risk MDS space, combined with agents such as the BCL2 inhibitor, venetoclax, and other new approaches. For patients, of course, it's nice to not have to come back and forth to the doctor's office repeatedly to get your hypomethylating agent. In the higher risk MDS space, however, to really move the needle forward, beyond having convenient formulations of known agents, it would be really nice to be able to have a new drug to combine with an HMA, and that would have a positive signal. Given the time constraints, I didn't think it would be particularly helpful to go through multiple early phase trials that led to these phase 3 efforts, but I do want to commend all my colleagues who are working in this space. You all know now that some of our more exciting agents, including pevonidostat, magrolimab, and the TP53 modulator, APR-246, unfortunately did not perform or outperform the HMA. and so their development at this time has been halted. But we are still holding out some hope for the ongoing trials for which we are yet to have a readout. So the randomized trial with venetoclax, with sabatolimab, and with a very interesting molecule, tamibarotene, which targets, area alpha expression in MDS. So what have we learned over time? We know that combinations need to be tolerable and they need to lend themselves to chronic dosing over extended periods of time. Patients need to be able to stay on these for us to be able to see a benefit. We need to do more careful work early on to figure out optimal schedules and sequence. And there will be a session on clinical trials tomorrow that I'm eagerly looking forward to in terms of, how we can be as thoughtful as possible to actually be able to, reap benefit for our patients. This is a very heterogeneous disease, as you've heard repeatedly. So it's possible that we are missing the signals because we are largely lumping everyone together. I borrowed this slide from Uma Buradi and Christine Koenig because I think it, outlines just, some of the vexing issues and the, our concern about lack of a safe exit forward for many of our combination therapies. Obviously, a couple of these we're still waiting for readout on, including the Verona trials and then the sabatolimab combination. But should we be trying to lean more into, targeted therapeutic approaches for our patients? So I didn't plan for ivosidenib to be FDA approved. It was yesterday now, it seems already like a blur when I, was putting this talk together, but many of you in the audience may know that now. So we have 3 agents in the IDH inhibitor space, ivosidenib and olutasidenib, which target mutated IDH1, and enasidenib, which targets the mutant IDH2. As you know, these mutations lead to production of 2-HG, which results in inhibition of alpha-ketoglutarate-dependent enzymes such as TET2 and epigenetic deregulation. And those 3 are FDA approved in AML, and we've been waiting for some traction in MDS. An obvious concern has been that these mutations are not very common in MDS overall. And we still don't have as much evidence about what the natural history is in MDS, but they don't seem to have a huge negative prognostic impact relative to IDH2 wild type, higher risk cases. So there have been a number of relatively small studies with enasidenib in IDH2 mutated MDS. There's no randomized data. It's a little hard to tease out the relative benefit, especially in various heterogeneous subsets of patients that have been investigated so far. But, clearly this can induce CRs in some scenarios, especially in the higher risk, especially in the HMA naive cohort. And I think, it remains to be seen just from the various studies what the impact will be in terms of duration of responses and survival. For IDH1 inhibitors in the IDH1 mutant MDS space, ivosidenib is now approved, really largely based on this experience in relapsed refractory MDS, single agent therapy with 18 patients, a CR rate of about 40% almost, and a relatively high overall response rates. All of those other responses were marrow CRs. But the interesting thing is that the median duration of CR was not yet reached. It was not estimable with a range in the 1.9 to 80-month range. So clearly some patients can stay on it very long. And so I think the question to all of us is, how to move this kind of advance forward. Is it an advance? Yes or no? I think it is. And I think the other challenge now is how to move it beyond the second-line space into first-line therapy. And so it's clear that the problem isn't that we don't know the biology of MDS. There's a lot to be discovered, but we do know that there are all these mutations, and it's the minority of patients who don't have mutations. How do we target this in a meaningful fashion? How do we find relevant pathways and drugs that actually can significantly impact natural history, and how can we work together to achieve that? So I thought I would make a quick plug for the effort that the NCI is going to be rolling out soon, but where a lot of work has been going on behind the scenes. It's a collaborative effort between NCI and many colleagues and industry partners to try to accelerate precision medicine trials for patients with myeloid malignancies. I am grateful that there's an MDS working basket, and we have been working in that context to try to come up with a way to target or develop trials, I should say, for some of the more obvious subgroups. And with that, I would like to thank you for your attention. So I know that hypomethylating agents remain the mainstay of therapy for high-risk MDS, but I am hopeful that we will be able to move beyond that, and I hope that this recent approval of ivosidenib in this space sheds, at the minimum, a bright light on a very vexing problem. Thank you for your attention.